Hello everybody and welcome back to the Functional Health Podcast. I'm delighted to be speaking to Dr. Nasha Winters. Nasha is a naturopathic doctor and a fellow of the American Board of Naturopathic Oncology. She is a cancer survivor herself, a co-author of the best-selling book, The Metabolic Approach to Cancer, and is actively educating healthcare practitioners across the world in this modality. This is but a fraction of her many achievements and accolades. We dive into diet and cancer therapy, what works, what doesn't, new oncological interventions, and much, much more. She has an amazing energy, and I'm excited to share this conversation with you. Nasha Winters, welcome to the show.
Thank you so much, Ben.
It's so lovely to have you on.
Oh, thank you, Ben. Great to be here.
So let's start off with a hard question. Why is diet such a contentious issue as it pertains to cancer therapy?
We're just going to rip that Band-Aid right off, aren't we?
Straight off.
Good. Well, I mean, first of all, Dr. Richard Feynman wrote a really excellent book called Nutrition in Crisis. And it so highlights this very issue, which is we do horrible studies on this, number one. We can't do the causation, correlation dance very well with this. Everything can be evaluated for or interpreted basically through the eye of the beholder.
Yes.
And most nutrition research is funded by conflicts of interest. Let's just put it mildly, or not so mildly. But so there's a lot of misinformation there. And then there's also this concept that we kind of keep trying to make nutrition a one size fits all. Impossible. Because we have this crazy thing called genetics and we have this crazy thing called evolution and where we came from. And so, if you came from the stock of hunter-gatherers, that you might need a very different approach to your diet and lifestyle versus if you moved into the Neolithic farming era, which is a whole nother need of changes. And if you were born after World War II, the world is so different. Our food is so different today. So you have to take things into consideration there. So what our grandparents, great-grandparents, great-great-grandparents were eating, it doesn't even look the same today. And so these are the things we have to look at our changes from the industry, but also our changes just over time of moving from hunter-gatherer into more of the agrarian society. So those things impact us. And so we can't really study very easily this information, especially when people can barely remember what they ate for breakfast. Most research, right? I don't remember. I mean, luckily I'm fasting this morning, so easy to remember what I didn't eat. But most people, you ask them, they honestly can't tell you. So most of our nutrition studies are based on memory and people's, their reporting. And I will tell you as a clinician for over 30 years, everybody lies, right? Or everybody misunderstands their portion size, or everyone tells me they think they don't eat any sugar until I do a diet diary with them. We bring on, the only way you can really start to know is macronutrient counters and, biometrics, like metrics of testing for continuous glucose monitors or HRV devices, things that really give you that feedback that's data, not just dogma or opinion or really bad misinformation or forgetting what it was that you were taking in. So there's so many variables to why it is just absolutely confusing around diet and nutrition. And then we have an entire training of nutritionists that are beholden to an industry. So in the United States, they're called RDs. I don't know if they're registered dietitians here as well. And unfortunately, they're not about therapeutic nutrition, not about the treatment or prevention of disease. They're about mitigating things like scurvy, or beriberi, just enough of the nutrient to prevent certain known diseases and very minimal amounts. So not into a therapeutic level. And they're beholden to the institution. They're beholden to the industry. So that keeps it a little challenging. I have a lot of recovering RDs in my practice. And I know I'm presenting to a pretty conservative environment, but there is a very big difference of registered dietitian nutritional advice and therapeutic nutrition advice. And rarely do those two meet unless people start to do the data evaluation themselves and come closer and closer to the middle.
It's true. I think there's a huge difference between stopping someone from getting a nutrition or deficiency-related disease and then optimal nutrition.
Yes.
And we know that is different from everyone.
Very different.
Even from a macronutrient standpoint, if you have more copies of the AMY1 gene, you're more able to tolerate carbohydrates and reduce insulin.
Yeah.
And And you've been a huge voice for the metabolic approach to cancer.
Yeah.
For people who may not be aware, what is this approach? Why should people care?
Perfect. Well, first of all, people need to understand right from the get-go is you have anytime, all of us at all times have cancer cells in our body. And our body does this amazing job keeping things in check. Our immune system is constantly on surveillance, knows how to respond when it sees something, and knows how to respond to it, and get rid of it or subdue it if it's misbehaving. Now, that's great when that part of you is working well. Mm-hmm. When it stops working well, those cells get a little activated. But they only respond, they only activate based on the environment in which they live. And that environment is determined by what we decide to give it. Okay, so everything from our light, our food, our water, our thoughts, the toxins that we expose ourselves to knowingly and unknowingly every day, basically anything we put in, on, and around us impacts that environment that keeps the metabolism and the mitochondrial function of the body functioning well or dysfunctioning. Mm-hmm. Pretty simple. When a cancer process takes off, when the immune surveillance has failed, when the environment in which those cells dwell in is failing, then the cancer takes off, and its personality and its metabolic behaviors are very different than our healthy physiology, our healthy cellular behaviors. They're two different behaviors happening simultaneously. Mm-hmm. And so people need to remember that. You both have to address the cancer metabolism while simultaneously addressing the healthy metabolism. And they are not the same thing. So what happens in both standard of care and alternative care is everyone wants to do the all the way on or all the way off switch.
Yes.
Doesn't work that way, right? Because yes, you can go after and focus and kill the crap out of the cancer cells, but you will take the rest of the healthy cells with you. Mm-hmm. And if you come in and just focus on the healthy cells, you may actually embolden or enliven those cancer cells if you're not mindful. So a good example of this is glutamine. Right? Glutamine is the most important nutrient for our healthy cells, period. Bar none. You will die without glutamine.
Yes.
And yet there's a lot of people out there saying you just have to restrict glutamine. You just have to get rid of it. You're going to take pharmaceuticals to block it. Well, you will also kill the body at the same time. So how can you hit both of those pathways and those patterns simultaneously? That's what the metabolic approach to cancer is all about. That's about evaluating the terrain and the environment in which that cancer took root. And then we can support the healthy metabolism, the healthy mitochondria right there. And then we get to hone in on the cancer metabolism and knowing the personality of those cancer cells, the cancer pathway itself to target that. So what happens then is even that's nuanced. So simply put, cancer cells predominantly across the board, they all utilize glycolysis. They all utilize glucose across the board, 100% of all cancers. Mm-hmm. So 100% of all people with a cancer diagnosis or trying to really prevent should start to carbohydrate restrict. The extent of which you carbohydrate restrict gets more nuanced as you learn more information about the tumor and the tumor process itself.
Yes.
And the metabolic process, because if people have, like their healthy tissues, if they were already diabetic, you got to probably work a little harder. Right?
Yes. Okay. I understand.
Yep. So those are important ones. When you come back to the cancer cells, though, if you know that all these cells use glucose predominantly, that's a really simple strategy across the board. 70 to 90% in the literature use it predominantly. Mm-hmm. Okay. So 70 to 90% of all cancer types use glucose predominantly. So that's why if you best guess, start there. The second most common fuel source for our cancer cells is glutamine. Okay, this is where it gets confusing because everyone is so then scared of glutamine. And yet there's a few things that happen. You block it, what happens?
Well, you're not going to be very well, are you?
Yeah, well, you're not going to be well, but also your body wants the glutamine so bad, it will start breaking down your muscles.
Of course.
It'll start binding it. It will start scavenging it from other sources to keep you alive. So you can't truly glutamine restrict. In fact, when you go into a fasted state, your body, for the first until all of the glucagon is gone, will start to pull the glutamine, like the glucose out of the system, and then the glutamine next out of the system. So it's always going to default to that. So you have to be mindful of that. And then there are some concerns that perhaps fatty acids can contribute to a cancering process.
Just to interrupt you there,
Yeah,
because you mentioned about fasting and how the body will utilize glutamine, what's available.
Yeah.
It does that through autophagic mechanisms, right? Rather than actually pulling it from muscles,
No,
tissues
both.
in the both.
Yeah. It will definitely, when you starve the body enough of glucose, it will go to your muscles for glutamine.
Yeah. Autophagy meaning the cellular cleaning mechanisms, right? Like
Which you go into autophagy as soon as 4 hours after your last meal.
Yeah. Okay.
You go into deeper, you go into really deep dive after 3 days water fasting, right? But it starts very shortly after you consume. And unfortunately today, most of our patients are, I've seen the studies showing that we eat an average of 21 times a day. That's not 21 bites a day, folks. That's 21 times we are constantly unconsciously grazing.
Yes.
And so you can't get into a state of autophagy when you're in that. You can't get your insulin down when you're doing that. You need to have breaks, right? And we evolved from a time when food was not available 24/7. And so now, and when I was even in medical school, I was taught patients should be eating every 2 to 4 hours. You want to keep them smooth. Really bad advice. And unfortunately, that's still the advice given in most nutritional programs today. We are now more metabolically broken than ever. Studies show that less than 7% of Americans, which I'm going to put y'all here in the UK in the same category. We're all eating the same way, okay? In any developed nation, over 93.6% based on several studies since 2018 through 2020 show that less than 7% of us are metabolically healthy, which means our bodies don't know how to go into that natural autophagy state, into that natural insulin reduction state. It's always high insulin, dealing with that 21 times a day that we're grazing. It's that fear of going hungry that we're always feeding.
Yeah.
So it changes it.
It's cyclical, isn't it? Because people which cannot tolerate carbohydrates or those kind of insulin spikes, if you restrict them from glucose,
at first
you'll get a pandemic of hungry people.
Yeah. And but the hangry goes away. It's known as carbohydrate withdrawal for a reason.
Yes.
The hangry's for a reason, or keto flu for a reason, or whatever is creating that state. There's that moment of discomfort, just like coming off heroin. It's the same mechanism, folks. It's affecting the same pathways in the brain.
It feels extreme to compare the two.
It does, really, which is ironic because all the biochemistry is the same. Our dopamine and serotonin receptors are most predominant in our gut and our central nervous system, including our brain. Sugar pushes that dopamine button. So we are literally walking around as a bunch of crackheads. Okay. And I know it sounds very,
you can't tell me my fruit is crack. I'm not having.
How does the sugar from fruit differ than the sugar from a milkshake?
I always think the food matrix is really important to consider here. The fact that it's combined with phytochemicals and fiber means it's going to have a different response in the body than just if I had several teaspoons of pure cane sugar.
And what does your CGM show you? It won't show you anything different.
The spike will be, the AUC might be the same, but the spike will be less.
So the spike will be less,
AUC
but the long game is the same.
Okay.
And so that's the trick is, so just going into the basic biochemistry, you're still feeding into the same pathways, the same Krebs cycle, the same, all these pieces, no different. And so it doesn't care if that came from a slice of bread. It doesn't care if it came from a sweet potato. It doesn't care if it came from an apple or low glycemic berries. It doesn't care if it came from a triple frappuccino from Starbucks. It doesn't care. It will have the same result. Most of us, we evolved from a place where we should be able to tolerate a little bit and have no issue. But who does a little bit today? So even when the American Dietetic Association in the United States suggests that a diabetic-friendly breakfast, honestly, you guys, is 3 days of sugar right there. And so we are really pushing our patients in a way that our bodies, we are treating now what's common versus what's normal. And so we think, oh, well, they have to have this because this is what's going to keep them functioning and keep them set. Well, we've raised the bar over time of our carbohydrate intake. Even the registered dietitians in the United States say we should all be eating under 100 grams of carbohydrate a day, period. And that women should be eating less than 25 grams of sugar of that total carb, and men less than 20. Who does that? Most people are doing that at breakfast every day. I'm literally citing the RD nutrition recommendations, and yet I will look at the breakfast they're serving my patient in a hospital And they've already given them 3 days worth of sugar. It's
Yes.
300 grams in that breakfast.
No, I agree with you. I mean, it's the same in the UK,
It
to
is,
be honest,
okay.
with nutrition in hospitals. But I think for active individuals, obviously context is key, right? I think
Well,
people...
active, describe that.
So if you are training, if you're an athlete,
Right.
where glycogen expense is like part of your training, because you'll be doing high intensity training, I think carbohydrate stores, keeping them top.
Darling,
No.
we're going to know. Well,
No.
what happens when you train? What happens to your cortisol?
Obviously increases, yeah.
And then what does that do to your insulin?
Okay, increases that as well.
Exactly. So my sickest patients are my vegan super athletes.
The vegan super athletes,
And
right?
I don't mean that in a harsh way. It's just the reality.
Yes.
They're carb dense because that's the nature of surviving on a vegan diet. To get your protein resources, to meet your protein needs, you have to, by default, get enough pulses, legumes and grains to get the pure protein, correct? Right?
Yeah,
So
absolutely.
that means right there, to meet your protein needs as an Uber athlete, you are carb loading if you're a vegan Uber athlete. So right there, you're already glycemically challenged. Then we add in the overtraining side of thing, because everyone's like, I'm training for my 10K, I'm training for my marathon, I'm training for my Ironman. Those folks then are revving in constant cortisol, which is pushing their insulin even higher. You bring those two together, because then the training, the nutritional advice for Uber athletes for decades has been carb load. Really bad information. And then we have those folks that are so oxidized from the overtraining, the nutrients required to recover the muscle from that, the nutrients required to recover the adrenal function, to recover the cortisol, to recover the insulin spikes, are deficient in our vegan diet. So B12, the fat soluble nutrients, vitamin A, D, and K, selenium, zinc, start to become very depleted. They get used up. Vitamin C gets used up in that stress response. And so now you have folks that don't have the vitamin D is one of our best metabolic support for our everything, right? Really powerful to helping your blood sugar response and your DNA repair and your tissue repair. Same thing with zinc. Zinc is all about the immune function, which of course, when cortisol is high and insulin is high, immune system is low. So I'm being provocative on purpose because everybody thinks who comes to me that they were healthy until they got cancer. Everybody thinks who comes to me, but I eat a vegetarian or a vegan diet and I work out every day. And when we start to dissect their macronutrient counters, we start to have them use HRV. We start to have them use CGMs. They start to realize the diet and lifestyle they thought were the best because that's what media and social media and influencers tell them. They're not actually listening to their own body's data. And so I'm a data-driven scientist, and I use labs across the board. Every single patient gets insulin, A1C, C-peptide, and insulin growth factor. Every single one of them. I have yet to meet a cancer patient with normal levels of any of those. Not one in 32 years, and tens of thousands of patients directly and hundreds of thousands of patients indirectly. And we have a database collecting hundreds of thousands of patients' data to tell you this. I have yet to find a cancer patient with a normal vitamin D level.
Wow.
Yeah, not once. Not once. I have yet to find.
Are you using normal reference ranges, or when you say like normal?
So
you know
normal.
what I mean? Industry
So
standard.
that's a good point. That's a very good point.
Yeah.
So normal. You right now we say that normal is 30. Well, in the United States,
per deciliter, is it? Yeah.
And so I will tell you right now, as a clinician who's been at this, patients under 50 have health issues.
Right.
Period. When they have under 30, they have cancer. And I know that's provocative, it's going to scare the crap out of people, but I need people to wake up because I don't want them to be my patient in the future. Because when I see a vitamin D under 30, I go looking for it. I know that there is no surveillance happening in the immune system. I know that the metabolic machinery is not working well. I know that epigenetic triggers are not doing their job because vitamin D is one of our biggest epigenetics, lever pullers out there. And so suddenly we know that over 200 genes are under complete control of our vitamin D optimization. We know our immune system doesn't function well without our vitamin D. We know that a lot of the therapies we use, from standard of care immune therapies to low dose naltrexone, which is used a lot in the cancer world, to even mistletoe, which is my jam, will not work as well if vitamin D levels are low. So all of these, it's an entourage effect of how we nourish people and how we support the nutrient deficiencies, which for cancer is always low in selenium, low in zinc, low in magnesium, low in vitamin C, low in vitamin D, A, and K, classically. That's across the board. And not almost all of those are depleted by the pharmaceuticals we all imbibe in on a regular basis.
And you mentioned veganism depleting vitamin.
All of those are
vitamin A
depleted.
and K.
Yeah, and D.
I think it's important to clarify that you get preforming vegans, but not everyone converts that very well or gets enough of it.
K1 isn't going to do anything for you. The plant K1 is,
exactly.
You only get the value of the vitamin K in its animal form. Same thing with vitamin D. Yes, you can get D2 from mushrooms, but they are not going to be the bioavailable. In fact, D2 is the only form of vitamin D we get toxic from. You do not get toxicity from vitamin D3.
I know that.
So we can talk biochemistry on that later. And then the other big one is B12. Yes, you can get B12 from different algae and whatnot, but again, it's a form that is not as bioavailable. And so I have a lot of vegetarian patients that we supplement with fish oil, with vitamin D, with B12, with the nutrients that are required to bring them all of the cofactors to make all of their systems go and flow. I have not been able to have that success with vegans, unfortunately. And so once I work with a vegan over time, I'm like, well, let's do what we can. Let's take you as far as we can. But we're using data, not dogma, because you're talking to a person who's 7-year vegan.
Yeah, right.
Okay. And then I was almost 20 years vegetarian. So I'm speaking from personal experience that it took me almost 20 years to stabilize my own stage 4 cancer process. And if I just gotten out of my own damn way, gotten away from my dogma, I would have changed this a lot faster. So I'm trying to help other people do the same. You don't have to wait 20 years to save your own life. You can start to make those changes now, and the data tells us that. So you mentioned SNPs earlier. You know, I learned as much as I'd love to be a vegetarian forever, it's where I actually prefer. It's where my palate is, where my heart is. My TCF7L2 genes, all of my genes around my metabolic processes I don't digest carbs. Well, I just don't. I don't make the amylase, where I've got the amylase, SNPs, and some of those issues. I don't do them. I'd love to be that way. But my insulin and insulin growth factor were ridiculous. My husband's the other example where he'd love to be a carnivore.
Right.
But he has all the SNPs that basically he eats any amount of red meat and he looks like he's a diabetic. Looks like he's been eating candy bars. Wow. We can watch it on his CGM. We can watch it on his ketone, blood ketone monitors. And he gets too much protein. His ketones drop and his insulin shoots up.
Wow.
We are all biochemically individual. And so if you believe the diet that's working for you is working, don't just gasp by, I feel great. Again, no one says to me, I was really, really sick when I realized I had cancer. They all tell me I was fine until I had cancer. Don't wait to get that diagnosis. The best treatment of cancer is prevention. And so digging a little bit deeper into your daily dietary and lifestyle choices that you think are working well for you, are you sure? That's where I'm really pushing your listeners to evolve to looking into.
I love that. I'm going to play devil's advocate a little bit.
I love it. I love the devil's advocate. Bring it.
Okay. Yeah. So there's this idea of carbosis versus ketosis.
Yeah. Oh, right? Good. Yes. Yeah.
Yeah. So Dean Ornish, huge advocate of a low-fat, low-protein vegan diet. This is an interesting one because he's published papers on prostate cancer. Yeah. And there is some evidence to show that...
prostate's unique. Prostate's a very different cancer type of all the cancer types. And he's Mr. Prostate. That's all that he's looking at. So I just want to be that caveat.
Yes. But do you think there is some utility to the mainly functioning on carbohydrates with very low fat over ketosis in some instances?
Well, first of all, I want to point out that when people, this is where a big myth I'm going to bust right now. Everyone thinks ketosis means you're eating a high fat, low carb, high protein diet. First of all, that's not true.
That's not true
at all. So a ketogenic diet is a high fat, low carb, normal to low protein diet, period. That is one means in which we can achieve ketosis. But we can also achieve ketosis, ketone bodies, through just carb restriction. We can also achieve ketosis, but bringing in ketone bodies in our body, just using exogenous ketones.
Yeah, supplements.
And we can also achieve it with just fasting. So, and just caloric restriction. So what I will tell you is Dean Ornish's work, what was happening in those patients was mostly caloric restriction. And if we actually went back and did the right studies to see, they would probably be in low ketosis. The ketone bodies, there's no studies out there that shows ketone bodies will provoke cancer. Not a single one. And the misinformation people read when they read the sensationalized headlines that fats feed cancer, first of all, bad trans fats and seed oils do feed cancer, but not the way we think. They feed it through the mechanism of stimulating inflammation, right? When we talk about fatty acid synthesis and fatty acid oxidation, people get confused because they're thinking that's coming in from the dietary sources. But when our metabolism and our mitochondria are being beat up, so are our cell membranes. And it's the fatty acid, it's like the destruction of those fatty acids that can be utilized. So the breakdown of those tissues can be what can perpetuate. But that's in extremely rare situations and really far down the road processes with cancer that's just been overtreated and has morphed and mutated into so many different places. That's why I barely mention it, because it's so super rare. With prostate cancer, it has a vulnerability in the fats, but if we bring in quality fats of the diet, so that's why I'm a huge fan of the low carb Mediterranean for my prostate cancer patients.
Right. I
have them pretty much avoid dairy unless we can get them to a place where we see it otherwise. And I really do have them pull back on the animal protein, but I base that more on their SIPs. So you'll see that, like, again, the ACSL1 or the APOA2, we might need to pull that back for them. But we do that until they stabilize, and then we can get them back to a diet that's actually more genetically fitting for them. But they're all in ketosis because they're getting there in either caloric restriction, using exogenous ketones, like maybe around their hyperbaric oxygen or radiation treatments, or just carb, like I said, carb restriction, caloric restriction, or even intermittent fasting. So it is part of that. So that's the part that I think people get hung up on, is that we're talking everyone should be on a ketogenic diet. No, everyone should be utilizing your ketone bodies as a very powerful tool that hits 100% of the hallmarks of cancer simultaneously, and then layer on the other dietary requirements necessary to help that individual's outcomes the best.
Yeah.
Yeah. Does that make sense?
That does make sense.
So I thought it's not even a devil's advocate. You're just speaking truth but we're getting only part of the story, I think, in that. Yeah.
So in terms of the metabolic approach to cancer, what's the biggest mistake people make when implementing this modality?
Wow. Metabolic approach to cancer is more than just the diet. So it's kind of this metabolic mindset. But I think one of the mistakes is folks feel like there's a one-size-fits-all protocol. And so to be aware that we need to go back to this sort of test and assess methodology so you can determine the best fit for the patient in that moment. So that's one mistake. But if you are implementing a metabolic flexibility lifestyle, which might get you into a state of ketosis from a variety of pathways we've discussed already, you need to help that patient be successful by, number one, testing. So all the people who think they're in ketosis or think they're carb restricting and they're not. So things like things like Chronometer or MyFitnessPal or some of those apps out there that are macronutrient counters is a really good tool just to help people go, oh, this is how I normally eat. So let me take a look. Oh, I just have to shift it, maybe a little bit or a lot of it, depending on their previous dietary lifestyle habits. That, and then testing. And so I'm not sure if I'm allowed to say brands, but I use Keto Mojo because they are the least expensive, both the actual monitor as well as the testing strips. So I have compliance with patients who are spending less than $1 a strip. Way less than $1 a strip is way more. I mean, when we started doing this, it was like $6, $7 a strip.
Wow.
With Abbott, labs, those testing. So we didn't use it as often. Now we have the luxury of using it a little bit more frequently.
And that gives you both glucose and ketones.
And with Keto Mojo, they also give you the GKI, which is the glucose ketone index. And an interesting side piece, another mistake that people aren't aware of, is that knowing that ratio gives you an idea of how far you are or how close you are to your goal.
Right.
So to give you an example, a typical Western diet, no matter where you live on this planet today, the average GKI, you ready for this, is between 25 and 30. Okay. What the work of people like Dr. Tom Seyfried has done from Boston College in the United States, who's really paramount in this field, is he's shown that the actual treatment, the actual using it like a chemotherapeutic agent, your GKI needs to be below 1. So when you realize people are 25 to 30 times, above that, that's a little daunting.
Yeah.
But we've even shown research, so people like Miriam Kalamian and myself who've done a lot of this work, just being the clinicians with the patient, not just in a lab looking at mouse studies, we have seen that patients are successful when they can get their GKI under 5. And so that's a goal that everyone, for prevention, people getting their insulin under 5 on the markers from the United States, getting their A1C under 5, getting their uric acid under 5, getting their GKI under 5, basically puts me out of work. That's my goal, right? And those are simple. Those are parameters of just a little bit of reining it in. That's not even going hardcore. When you need to go hardcore in some of the therapeutic environments, you're going to have to restrict a little bit further. But that general rule of thumb is for people to understand where they start. So doing their own GKI, getting a glucose read and getting a ketone read, and then doing the little mathematics, which does it automatically on the Keto Mojo monitor, but you can also simply do the equation yourself if you're using other monitors. Will show you how close or far you are from that goal point of the less than 5 GKI.
Right.
So that's big. And then the third biggest thing is people aren't prepped to know how to hydrate and electrolyte themselves. And so most people who struggle with the side effects of carbohydrate restriction, we mentioned earlier, carb withdrawal is a real thing, keto flu is a real thing, and they're almost always associated with people having electrolyte imbalance. What happens when your insulin starts to drop? So does your sodium, so does your magnesium, so does your potassium. These are really critical players in just your feeling good, right? And your cells being able to function properly, and your signaling pathways being able to function properly. So if you can bring on good sugar-free electrolytes, holy schmoly, it's a game changer. And we like to start patients on them right away, not waiting until they're in ketosis, so that they've got a little bit of a buildup ahead of there. So those are some of the biggest kind of pitfalls and myths. And then we also talked about the myth of people thinking that this is an all bacon and egg diet.
Right. Yes.
And maybe that's where we pause and move into the next, because I know you want to talk about concerns around animal products, meat in particular, and dairy, because that's where the old Atkins approach, that's what most people think of keto, they think Atkins. And honestly, that is the worst diet for anybody with cancer. Or trying to prevent cancer.
Yeah, because the meat and dairy, the internet is littered with information on how meat and dairy increase IGF-1, mTOR, and how this relates to cancer.
Right.
So what's the story with meat and dairy and cancer?
Well, it's interesting. So I have a couple of colleagues, Dr. Chaffee, one of them, Sophia Clemens, that are folks who've worked with cancer patients using an entirely Paleolithic ketogenic diet, which is basically a pure carnivore diet. Now, I respect their outcomes. I respect the real live patient stories I've seen, the real publications they've done. But in my own practice, when I'm testing these patients, I'm looking at their regular labs, I'm looking at their functional medicine labs, I'm looking at their single nucleotide polymorphisms. I have not been as successful with that.
Right.
I might short-term use carnivore for someone who's just got major gastritis after taking an immune therapy. Honestly, barely anything works as well as putting them on a few days to a few weeks of a full carnivore diet, because it will really reset that microbiome and really take that inflammation out and really lower the risk of all the lectins that come from everything else, just adding more insult to injury. But once that fire is out, I really want to get them back into an eclectic diet. We want diversity as well in our microbiome to function well. And so I also, because I test so much, I can see very, very quickly what too much protein, whatever the source, does to the insulin levels, does to the insulin growth factor. If I have patients' blood or tissue assays from their tumor type, then I also know if mTOR is a player for them, or PIK3CA is a player for them, or MYC is a player for them. These are certain oncogenes and tumor markers that are incredibly sensitive and vulnerable to too much protein. and that can drive this train right off the bridge. And so again, it's not a one size fits all. And because I test everybody, I know how to pivot and move with the information I'm getting. So if I'm starting with somebody on a diet that is not a fit, I'll know right away from their labs. It's not about my opinion of it. Maybe I've got a general, as we talked about earlier. Maybe start everybody in carb restricting. Great, start there. Then knowing how far you have to go, the other data points will drive that point home. But as far as protein being a real driver, the evidence is very clear that too much protein can be a problem. But don't take my word for it, test for yourself, because clearly from some of my colleagues, it's worked very well for some of their patients. So I don't want to negate, anecdotal results are still that. These are real humans with real responses, and we want to absolutely take that in as data as well. But we can also start to construct better studies and maybe gather more information to know who does well with certain diets and who doesn't. As I mentioned before, my husband would love to be the carnivore. Not so much, right? And I would love to be a vegan or at least a vegetarian, but my body, it's like, not quite for you. Now, mind you, when I say I eat meat or animal protein, we're talking, a serving of fish a week, maybe a serving of poultry, a few eggs a week, and maybe a couple times a month, maybe a small amount of red meat. Like, I'm not a big animal protein eater because I just don't crave it. But my body and my labs will guide me to say, we might need to top off the oil gauge a little bit. You're dipping a little low. And so I know pretty quickly, my iron stores drop really quickly. My energy drops really quickly. My B12 drops really quickly. I've got pernicious anemia. I've got a lot of autoimmune stuff. So I've got pernicious anemia, a lot of leaky gut stuff. So for me, I have to be very mindful of what I fuel my cells with. And being a 32 and a half year stage 4 cancer thriver, I don't take this lightly. I know that I've been offered decades beyond my expiration date, and I want to take full advantage of that. And so for me, I've learned a lot from myself to apply this to others.
I mean, your story is always so inspiring.
So it's very good for me.
Your story is always so inspirational every time I hear it.
Well, thanks.
How's it going now?
Well, my gosh. I mean, first of all, the first 10 years, I wish I had me the first 10 years. I didn't know what I didn't know until I know, right? And so it was very difficult. It was very bumpy. It was very in and out, very non-linear. I mean, first of all, cancer, the process of cancer is very non-linear, right? It's not like, it has this starting point and then it goes just naturally to this trajectory, and then you bring on this treatment and then it naturally goes this. It doesn't work that way. So for me in the first 10 years, it was kind of like holding on for dear life and figuring out, well, that didn't work. Okay, pivot quickly. That was how the first 10 years. The next 10 years were kind of, I hit a sweet zone. It's like, I'm in a great holding pattern. And the last couple of years, just to be very transparent with your listeners, I moved into, first of all, a stage 4 ovarian cancer patient to move into a natural menopause is pretty remarkable, right?
Yes.
So that usually strikes people as weird because they would have assumed I've had all my parts taken out or cut out or chemoed or radiated. But I'm also weirdly in my own family of origin, the only natural menopause that's ever happened. All of my mother, my grandmother, my cousins, and they're all I'm the oldest of all my cousins on my mom's side. There's not a uterus or an ovary left. Everyone's had complete hysterectomies from either cancers or endometriosis, polycystic ovarian syndrome, all the diagnoses I had at a young age. And so I've managed to actually reverse a lot of these other conditions. So the bumpiness of perimenopause was very humbling. I realized, wow, what was working for me for this past decade, I have to change course. I fasted a lot more before. In perimenopause, I had to change my fasting schedule. It was draining my adrenals too much. So I had to literally fast around my cycle. So my dear friend, Mindy Peltz, her book, Fast Like a Girl, and her book, Menopause Reset, was really an inspiration and a guidepost for me. Even though I'm a clinician, I'm still a patient.
Yes.
And so you kind of forget, you're like, oh yeah, worst patients, by the way, the clinicians. To start to move and work with that was such an eye-opener. It made the whole experience so smooth that all of my other girlfriends going through perimenopause and menopause, they just marvel at how non-symptomatic I've been. They're just like, how? And I'm like, well, I had a few moments, but I rearranged a few things and it's been smooth sailing ever since. And they're all shocked. Oh, you're not taking hormones, you're not taking X, Y, and Z. I'm like, no, especially no. With my history, my SNPs, my background, it's a hell no in taking those things. And so I had to do it through dietary and lifestyle intervention. So for me though, I also notice when I don't take care of myself, I have this, because standard of care would never consider me no evidence of disease. But my terrain, my trifecta, my C-reactive protein, lactase dehydrogenase, sed rate, perfection. And if one of them starts to go out of range, because I test at least annually, more so if things look a little funky. I started having some things look a little funky a couple years ago as I moved into the perimenopause. So I started testing more regularly, about every 3 months, so I could watch it and see. Once I went through the menopause door, things smoothed out. And my diet, I can fast more now because I'm on the other side, doesn't affect me as much anymore. That was really instrumental in normalizing a lot of my labs. And then I ended up with some crazy, I had COVID a couple of times, which wreaked havoc on, there's a couple of things we know in the literature that it's impacting the ACE receptors, which is going to impact your hormonal health. So I had to change up some things in my diet and lifestyle to overcome that. My point is that I'm using information to give me feedback that tells me what I need to adjust. And it's not me guessing, because I don't have the luxury of guessing. Most people with cancer don't have the luxury of guessing, and yet that's how most of us function.
Yeah.
And we take sort of, well, this literature states, well, you're not a textbook. You are your own biochemical, individual, like fingerprint, blueprint of yourself. And so that's where I'm hoping people hear this, that this metabolic approach is so much more than just how you eat. It's all the things that impact your mitochondrial health. It's all of the information that those little receiving, these little receiving organelles take in and then translate and then send signaling and information back out. They depend on us. And so we are far more powerful than we've been led to believe on how we can impact the outcome of either prevention of disease, treatment during the process of a cancering process, and survivorship after you've stabilized it or overcome it. And so that's where I hope people feel more inspired and empowered to go further than what just maybe standard of care has to offer. Yeah.
Oh, Nasha. Amazing. Cool. I mean, that is true personalized medicine.
It is. The beautiful thing is today is we all really do have access to this, even whatever your socioeconomic status. Many of the tests I run with patients are covered by your national health services or by your insurance process in other parts of the world. These aren't out of the range, wacky doodle, high dollar functional medicine tests. And then there's so much you can do just listening to your own body, asking yourself questions, taking the Terrain 10 questionnaire and understanding what it is that you are. Yeah. And well, the one in the book is like a very abbreviated, but we can put it on the show notes here. We can put the extended version to go deep dive, that people can really know what their priorities are, maybe what their blind spots are, to say, I should probably start paying attention of when I go to bed and when I get up. I should maybe pay attention of when I actually eat my meals. Because people this is what I also love. Like I'm a foodie and all about diet, but people like Dr. Sachin Panda.
Yes.
He's like, it might matter more about when you eat versus what. And there's that wonderful study that came out a few years ago about the breast cancer thrivers, those women who fasted for more than 13 hours, so 13 hours or more every day, which is basically, guys, finishing dinner and not breaking fast until 13 hours later after breakfast, at breakfast, they had a 70% reduction in recurrence of breast cancer. This study has been really hailed. And they didn't ask what those women were eating. They just looked at when they were eating. They could have been eating Twinkies all day and it probably made a difference. But as we talked about earlier, we've all been trained like eat, and be terrified if you snacks. I got snacks in the glove box. I got snacks in my purse. You watch people like constantly giving their kids snacks. It's like, we can really retrain ourselves to realize that we don't need to depend on snacking or even three meals a day. Those are kind of concepts that have been brought up by more industry than reality. And where in evolution did we have 3 squares a day? Where, like, when we were hunter-gatherers, were we like, most important meal of the day, get in that breakfast, and this has evolved. This is sort of a new phenomenon. And there's so many cool studies I've read over the years that show that we, of course, ingest way more calories today than ever before. We never, historically, we weren't really 3 square meals a day. That's kind of a newer evolution since World War II as well.
Yes.
And so it's like, gosh, we've got to help untrain people from that sort of habitual. Like my mother, bless her heart, she had like it's 7:00. You got to eat. Like there's like this internal clock. And when she comes and hangs out with my husband and I, she just spent 2 weeks with us in Mexico. And we had her down to, by the end of the time, she was down to 2 meals a day. She's like, I feel much better. And she realized saves time, saves money, saves time. And it was just crazy.
Mental bandwidth, because you don't have to think about the meal.
100%. 100%. So it was really cool of like, oh, I just have to cram something in because it's time to, I'm really not hungry right now. Do I need to eat something right now? I can push this a little bit. And so like when we start with patients, we like to say, well, let's our first step, when you talk about what's the first step? Well, the first step is knowing you're more powerful than you're led to believe. The second step is breathe and realize that usually unless you've had some really rare emergency situation with your new cancer diagnosis, so maybe there was a blockage or some valuable real estate in your anatomy that's being taken up by a tumor that's prompting you to end up with emergency care, your diagnosis is often not an emergency. And yet the diagnosis itself can sure feel like one. So I want people to take the time that's needed to gather information to make the right choice for themselves to move forward. And that might take 2 or 3 opinions. And that might take some reading of certain materials or listening to some other people or adding to your team, not just your oncologist, but bringing in your nutritionist, bringing in your rabbi or your priest or your, like your spiritual advisory, bringing in your loved ones, your close ones, bringing in your acupuncturist or whomever you're working with, your integrative provider, so that you have this beautiful board of directors in helping support your decisions and how you move forward. Because I'm telling you right now, your conventional standard of care team, they are experts in tumor. They are not expert in you, and they are not expert in terrain. Medical schools in the United States, at least, less than 25% of all medical schools in the US even offer an elective course in nutrition. Would you take nutritional advice from someone who's never had a nutrition course? And yet we do every day.
Yeah.
Right? Just like you don't want to take advice from me on how to fix your car. Or even how to run your review.
A part-time mechanic.
Right, there you go. It's so that's a place is find people who are good in their lane.
Yes.
Right? And bring them to the table and let them hash it out, not put you in the middle of being the middle person, because the data is there to support these choices to go otherwise. And then when we start to look at the cheapest and easiest place to start with changing your metabolic health and your metabolic expression, the safest, fastest, freest, easiest is starting to time restrict your eating.
In terms of the question, what is the first thing people should be doing when they're diagnosed with cancer?
Yeah. Well, and that was just it. It's like ask questions, gather your team, take a breath. There's time, right? That's very, very important. And we can also put in the link, I actually have a kind of 5 steps to do after you're diagnosed, which part is pretty much what we just talked about. Starting with the fundamentals. Don't just say, oh, you have this. I mean, a really good example is someone that's here at this conference was told on May 3rd that she had probable lung cancer, and they were ready to start her on treatment that day. Had she not had known people like me, she would have jumped right into the NHS treatment, a very aggressive treatment for what is considered a very poor prognosis cancer type, and would have been in trouble because she took that pause. It was found sort of incidentally. She took that pause, she gathered more information, and a month and a few days later found out it wasn't even lung cancer. It's lymphoma. The treatment would have taken her life. Very different treatments, very different approaches. So she's now humbled to the core to realize, oh my gosh, the pause is very important, right? But she spent that month getting that data. She put herself into ketosis. She dropped a stone in a matter of weeks. This woman was metabolically inflexible. Her blood sugars were up. She had no idea that she was diabetic. None. Because she doesn't look it. No one would look at her like diabetic. She eats great. She exercises. She does all the things. And so she's the perfect example that her taking that much needed pause, bringing her team in, lots of great people, including nutritionists, naturopathic oncologists, conventional integrative oncologists, bringing all of us to the table. We had her, right? And now we're gathering even more information because now they're trying to start her into this particular treatment, but they don't even have the type of lymphoma yet diagnosed, and they're ready to start her into treatment. I'm like, she's symptom free. Let her have another week or two to get this information.
Yeah.
And when we get that, then we'll know. Papillary, follicular, B cell, that matters to your outcomes, is to know as much as you can about the tumor, but simultaneously as much as you can about the terrain to enter into a really can be a challenging time in the treatment here. You want to be at your absolute best. It's like preparing for a marathon, right?
Yes.
So that's what she's doing. So she's getting ready to go into this so prepared, so ready, already metabolically flexible, that whatever tools she brings on top of this has a better opportunity to land. Because remember, having those ketone bodies, as we mentioned before, already make the cancer vulnerable. So whatever other treatments you bring on board are going to be even more on target and less on terrain, which is really, really good medicine. And so for her, it started with a little bit of fasting. Okay, shoot for that 13 hours first.
It's free, easily accessible.
Yeah.
Makes a lot of sense.
The first where you get it, this is what's interesting, is you can start to ask folks in our questionnaire, we even say, how do you feel if you go 4 hours without a meal, 8 hours without a meal, 12 hours? So patients will tell you, most patients can't, the majority of them can't fast for more than 4 hours. And when we can work them, you say, we're going to shoot for 13 to start. And if they're like really wobbly at 10, you're like, by all means eat. We ease you into it. Once you've mastered 13 hours, which everybody should be able to do, everybody, there's no excuse. Your children even should be able to finish dinner and go until breakfast.
Right. Yeah.
Right? No problem. No snacking late at night. Those are the clues. If you can't, you're metabolically inflexible. And then we have them test their urine ketones. If you are already metabolically flexible at 13 hours, you should see trace ketones in your urine. Right? Simple. $6 off Amazon. Buy those and check for yourself. Once the patient becomes showing medium to high levels of ketones on their pee strips, then we can start to move them into blood testing. Because over time, once you become metabolically flexible and fat adapted, you shouldn't actually be seeing ketones on your urine tests anymore. Once you become metabolically flexible, you're not breaking down the acetone in your urine. So people are like, well, I'm still seeing my ketones 3 months later. I'm like, well, you're still not breaking through to the other side, baby, and you're struggling. We're not getting to that therapeutic stage. But once we start to see the ketone levels go high in the urine and then stop seeing them, we can move into blood testing.
Okay.
And the blood testing is where we start to look at the beta hydroxybutyrate. And that's what seems to be the magic sauce to actually start to pull all the levers and have all the impact on the hallmarks of cancer. So when patients say, oh, I'm eating a ketogenic diet, or I'm eating low carb, until you start seeing some trace ketones on you're not. And that's just fasting. That's not even altering your diet yet. So then when people get to the point where you see your blood ketones and you're happy with where they are, be it therapeutic or nutritional, so like a 0.8 to 3 is kind of the zone, right, of where you want to be in anywhere in there, depending on the cancer type. But once you have that, then you can go and do things like the CGMs or the breath testing. And those are more telling you about how are you reacting to certain foods? How are you reacting to life? Are you over-exercising? Are you under-exercising? Is your workout causing your insulin, your glucose to spike and your ketones to drop? Or is it making your ketones go up and your glucose drop? Then you can even titrate your lifestyle choices around this. And so here's this amazing instant feedback. And in the US, we've even gotten companies like Virta and other to get insurance coverage and reimbursement to actually have their ketone monitors.
Yeah, Steve Finney, isn't it?
Yeah.
Better health.
Exactly. And these guys have made such a wave that they're actually getting patients covered to get their ketone testing done, to get their glucose testing done.
Amazing.
And it should be, and I know they're working hard to get it here in the UK as well. But these are the ways that you can empower somebody. When somebody gets that first time they got to 13 hours, something happens inside of them. They feel proud of themselves. They feel like they have overcome something. They realize that, wow, there's a powerful mental approach to this, as well as a physical and physiologic approach to this. And then it just takes them further and further. And so ultimately I start the patients at 13 hours. Once you master that, push you to 16 to 18 a couple times a week. Once you master that, maybe a 24-hour once a week. And once you get to that, patients, and this is based on people like Dr. Longo's work as well, a 3 to 5 day water fast a month while you're cancering, and at least seasonally after to keep the cleanup going. So
what do you think of the fasting mimicking diet?
Well, it's interesting. When I first
you mentioned Dr. Longo's
it's
work.
one. It can be a nice crutch for people because when you look, first of all, have you ever tried it?
Yes.
What did you think?
I actually prefer just straight fasting.
Me too.
Yeah.
And for me, maybe because of all my autoimmunity, it wreaks major havoc on my digestion.
Okay.
It's also not low carb. It's actually very high carb. And so I will watch my ketones tank because it's hard for me to get out of ketosis today. But the Prolon diet takes me out of ketosis very easily, more so than even like a margarita. I would prefer the margarita over Prolon. But that's where it's like, for some people, that crutch is really a gift. And even Dr. Longo, before Prolon came to the market, he always said, water's always better. And then he even said, until I have a product that goes with this, no one will fund my research. And then he even said, in the interim, you can make your own fasting mimicking. And he would make the suggestion of like bone broth, maybe some baked kale, and maybe a half an avocado, just keeping a 500 and below count. Olives, like those things, dill pickles. Yes. So anything that's kind of like, just if you need a little nosh, cheap, I'll do a couple tablespoons of avocado, a couple tablespoons of sauerkraut, that maybe a little cup of bone broth. You're still caloric restricting, you're still fasting mimicking diet, and you're still getting the benefit that a lot of people want. So if they're needing a bridge, depending on where people are psychologically with their attachment to food, we'll use things like that. And for some, they love the fasting mimicking, but it's $250 a pop.
Yes,
and so it's expensive. I'm like, it's a lot cheaper to buy a few avocados and a jar of good raw sauerkraut, and
I can see where it's coming from though. For people that want to eat, you can actually prescribe them a diet and then
exactly.
It
takes the guesswork out, right?
Exactly. Yeah. And that cognitive mental bandwidth for people who are busy, they have, crazy lives.
100%.
I can understand why it works.
Yes.
But
huge
you're right.
utility.
Yeah. Fasting, cheaper, and easier.
Exactly. And tastier. At least for me. I have a lot of people who swear by it. And this is why I love, there's that biochemical individuality. There's that personal preference. There's the mental emotional attachment. I mean, food is emotion. So that's a big one that no one talks about in this world too. It's like, you can tell someone you need to eat this way to survive. But when we're gauging our patients, we're interacting with them, we also want to understand their relationship to food.
I mean, if I'm stressed, I am craving chocolate, right? And if it's in the house,
it's gone.
It's gone.
It finds its way to you. Well, and that's even things like that. We'll ask people, what is your go-to when you're stressed? Or what foods do you crave? We try to then sort of upgrade them. I try to kind of make them, okay, great, you crave the chocolate. How do you do with like an 85% or darker?
Yeah, so 85% of the bit of nut butter on there.
Like like medicine right there.
Yeah.
Right? And it can, and a little bit goes such a long way.
Exactly.
Pops you out. So it's not never. It's like, how do you upgrade it? So like my winos, we'll use this example. A lot of my folks, the hardest part for them is letting go of the alcohol. Now, if they've got liver meds or stuff going on with their liver, we don't. I mean, ultimately, when you're putting a lot of poisons, chemicals like chemotherapy, and you probably should avoid the alcohol anyway, but some folks just won't. So we try and upgrade them. It's like, okay, well, let's stay with the white, like vodka, white tequila, with a little bit of like soda water and lime. Like if you have to have your cocktail, or wine, okay, go for a dry farmed. So an example in the United States, like a red California Sauvignon, or like Cabernet, is an average of 20 grams of sugar per glass.
Right.
Okay. So no, you don't get that anymore. Done. Whereas an entire bottle of a white wine from Spain that's been dry farmed, because it's when you bring in the water. What's the word I'm looking for? When you water it, irrigation. You become my notes. Sorry. I need some ketones. When you bring in irrigation, it brings up sugar content. And so the dry farmed wines, like in parts of Spain, Italy, Croatia, Greece.
Yes.
The entire bottle is less than 5 grams of sugar for the whole bottle.
Wow.
And so people can upgrade to something better, right? And so I
mental note taken.
It is, right? It's like, okay, if I feel like a treat, or if I'm out with friends, I'm like, okay, I would like to be with my friend. Well, I know what to look for in the menu. It's like, okay, I look for a Spanish or a white, an Italian white. or just a shot of tequila with lime. Great. So
I can tell people's ears have just perked up as soon as you mentioned that.
And the dark chocolate probably did it too.
Yeah.
And so we're still human, right? We still have our things. And because there is such an emotional attachment to this as well, we'll bring something joyful to the table. Bring something, bring some gratitude to the table. Find those workarounds.
Yeah. I love that.
Yeah.
What's the most exciting oncological intervention on the horizon for you?
Oh my gosh, there's so there's so many. I mean, it just blows my mind. I've been at this for so long that first of all, I never thought I'd live. They told me in 1991 that I wouldn't see 1992. Okay, so then it was sort of like every year after, it's like, oh, I'm still here now. What? I'm still here now. What? I'm still here now. What? Up until about 10 years ago, I would have thought in my lifetime I would never see the changes I've seen today. In the last 2 to 5 years, there has just been this unbelievable explosion of true integration, bringing the best of what standard of care has to offer, maybe even in some kind of repurposed and re-envisioned ways. So now that we can actually test for what chemo people are going to respond to, we could start there instead of, let's put you on this particular treatment and wait and see what happens and then move over. We can know right up front which treatment's the bullseye. Then we have these concepts known as metronomic chemo, meaning using a smaller dose of it to just push back. This adaptive theory of cancer is a big evolving theory of cancer of how we treat it.
Yes.
So today's maximum tolerated dose, like let's napalm the field and see what's left. Hope there's something. Rarely is there. That causes problems. But this adaptive theory is really emerging. People like Dr. Gregg, Dr. Gattenby, all of these guys are doing this work that says, maybe if we just push it back enough, the rest of the body could come back in and do what it was meant to do. Like we talked about the immune system earlier.
Yes, exactly.
And so that is very exciting, a huge surge of research in that arena. The combination, people finally realizing, okay, we can bring on metabolic therapies such as phenylbutyrate or 3BP or hexokinase inhibitors or these DAwn inhibitors. These are the glutamine inhibitors done with you have to do those, by the way. They will not work if you're not metabolically flexible, if you do not have ketone bodies on board. So everyone's wanting to go out and buy and find these drugs out there, but there's not an easy button for this, folks. Your radiation fails you if your insulin is high. Your cancer cells are desensitized in the high insulin and glucose levels. But we also suspect that that's the case for most chemotherapy as well. Your imaging, I mean, for crying out loud, patients aren't even properly prepped to go do their FDG glucose uptake for their PET scan. They're told just to carb restrict. Well, no one knows what that means. So they're like, well, I just had one piece of bread before the scan. We strongly carb restrict, pull it out entirely for 48 hours before and have the patient 16 hours fasted going in for their PET scan. So we can actually read where the cancer truly is and not where just your last donut has gone to in the body.
Yeah.
So it's like we can even use our imaging more effectively. So I get excited about those types of combinations. And then a therapy that's actually been approved since the 1960s for cancer care, photodynamic therapy, which is bringing on a photosensitizing agent, could be pharmaceutical, could be nutraceutical, could be herbal, along with a particular frequency of light that works with that agent, along with oxygen, creates this really powerful cytotoxic effect on the cancer cells. And we have dozens of cancer types that this has been studied on and approved for, and yet no one hears about it. You can use it superficially, you can use it intravenously, you can use it intratumorally. And so it's not a medication per se, it's a treatment that interfaces with a medication.
Okay, yes.
And that combination creates this really powerful anti-tumor effect. And then the other one a lot of people are hearing about all over the world, it's actually been around for a long time too, is the heliotripsy, the histotripsy, which is basically radio frequencies busting up cancers. We call that sonodynamic therapy. We've been using that therapy for decades as well, and no one seems to hear about it. We actually have sonodynamic therapy, photodynamic therapy, and even hyperthermias sitting collecting dust in corners of hospitals all over this world because they don't bring in the same revenue as the almighty chemotherapy, especially the new sexier targeted versions or the new sexier immune therapies, which some of these can be upwards of $1 million US a year.
Yeah.
And so when you look at that, they're like, where are we going to put our energy? Where are we going to put our money? Well, we got to get our ROI on the investment we made into those multi-billion-dollar drugs, multi-trillion-dollar drugs. And so these other therapies are also not so passive. The practitioner or a set of practitioners have to be part of the photodynamic therapy treatment. You can't just hook somebody up to an IV and walk out of the room and go about your business. So our medical system is even structured to just efficiency and how much time in the chair and how many people had to serve that patient. That's who's running medicine today.
Yes.
Not the patient in the center of this equation, and not the clinician and the patient and the patient's family members, caregivers, and the nutritionists and the integrative expert coming together to say what's best for this patient. And that's where I get excited, is I think that is the other big thing on the horizon, is this kind of board of directors piece we talked about earlier, all coming to the table. There's huge movements for this. I mean, we've got 600 clinicians trained in 36 countries now, bringing this into academic institutions, hospitals, clinics, a combination of conventional oncologists, conventional radio oncologists, MDs, integrative oncologists, naturopathic oncologists, PAs, you name it. We're all coming together because we're seeing that the system as is isn't enough. Yeah.
You've brought so much positivity to, I think, an area which, especially as it pertains to this complementary space, can seem so dark sometimes.
Yeah.
I know you're a huge fan of mistletoe therapy.
Yeah.
Is it something that you do yourself?
Oh, yeah. Yeah. So it's funny. I had a patient bring this to me in 2003, and I'd heard about it, but I didn't think we could get it in the US at that time. So I was already 12 years into my own diagnosis and had already tried a million other things. So this patient comes to me and says, I'm going to give this to myself if you don't help me. She's like, I'm going to do it with or without your blessing and with or without your help. So she forced me to learn. This was a patient with a very aggressive inflammatory breast cancer, mets everywhere, in her liver, in her lungs, in her brain, in her bones, in her lymph nodes, everywhere. She was given just weeks to live. She lived 9 extra years. So with cancer, thriving, kicking ass and taking names. Like, she was amazing. And so it was her that pushed me to explore this and start to use it in all my other patients. It still took me, because this is me being the doctor, the horrible patient, it took me another few years to start applying it to myself.
Of course it did.
Of course it did. And so I think I started using it for myself in about 2007 or 8. And I followed the typical 3 times a week protocol for a while. But now, here in 2024, I just use it every Christmas, every December. I do a box of mistletoe because I love the metaphor of it. So my husband and I, we kind of joke, because I actually have him taking it too. He's got a strong family history of cancer. He had a sarcoma process in his knee. So we kind of do our kissing under the mistletoe, but it's our injection instead of the dangling, berries. Yeah. And so it's something that I now do as an annual sort of tune-up to my immune system. And we actually have a book called Mistletoe and the Emerging Future of Integrative Oncology, that people could read about this. This is written with a hematological oncologist, with 3 other medical doctors, with 1 other naturopathic doctor, and myself. And we go through our own collectively 150 years of experience between us, as well as over 300 references, and really the history, the background, the research in this. This book is actually a nonprofit book, so any funds that do come into it go into further research in this arena. But it's a tool that I think should be implemented at some point in everybody's cancer journey. And it's just one of those really powerful things. So when you talk about what's in the future for me, I've been using it since 2003. So 21 years later, it's still my favorite go-to. I can't think of a single cancer type or a single instance where I wouldn't use it.
High praise.
Yeah, it's a big one. And it's especially, it's easier access for you here in Europe and the UK than in the US.
Widely available.
Big time. Yeah. And if you live in like Germany or Switzerland and you're diagnosed with cancer, the percentage, it's about 80% of the population, and that will use mistletoe at some point, just still today. And the rest of kind of Europe around that region, it's about 40%. In the US, it's probably 5%, if that. And those are because of people like us who are training more and more. I've trained now upwards of over 1,200 physicians in how to apply this clinically. But the research just continues to grow. And this, I think at this conference, there were at least 3 talks on this, and both, I think, Helixor and Iscador, 2 of the big companies, have a booth here at the IPM. And so it's making its inroads out there. And in fact, I'm taking a group of 19 doctors to Switzerland in September to take to the hospitals in Switzerland and in Germany that are employing this in conventional oncology hospitals. And we're teaching them how to do intratumoral mistletoe and intravesicular mistletoe and intraperitoneal mistletoe. We're showing them the sort of more modern and medicalized versions of this beyond subcutaneous and beyond IV, because a lot of people just assume that this isn't medical. And yet this is going to be in hospitals where they're doing chemotherapy at the same time, and surgery in the same place. It's like, this isn't alternative, folks. What we're talking about is and should be standard of care.
Yes, absolutely.
Yeah.
I think it's why we're here.
Yeah. Well, and even down back to the food piece, even Tom Seyfried, they've got several published papers now about how if you're diagnosed with a GBM ketogenic diet, now it is truly the ketogenic diet, high fat, low carb, minimal protein, should absolutely be standard of care in every patient diagnosed with primary brain tumors and specifically GBMs, because that's where most of the success has been found in the research. There's a 5-center study right now with Cedars-Sinai and many other academic institutions in the US with Dr. Hu and LJ Amaral, who are rocking this. They've already moved through phase 1, moving deep into phase 2 and 3. And they're like, this is among hundreds of patients with GBM going through this process. Like, how is this not standard of care? And when the big academic institutions can apply this, why can't the smaller clinics and institutions apply this as well?
Sorry, GBM.
Oh, sorry, glioblastoma multiforme, which is, you pray that that's not a cancer type you'll be met with, but unfortunately it's one of the fastest growing cancer types on the planet today.
Nasha Winters, it's been an absolute pleasure to have you on the show. You're a true inspiration, a well-needed voice in the space, and I absolutely appreciate you.
Thank you so much, Ben. I really appreciate it.
What does the next 6 to 12 months hold for you?
We just opened a lab.
Yes.
So metabolomics, R&D, and cell mitochondrial respiration lab. So that's what we're opening up. We've also got our continued training our clinicians globally. We keep bringing on 2 cohorts a year of clinicians as well as patient advocates. We have the land donated for our first in the world metabolic oncology hospital and research institute on a 1,200-acre organic regenerative farm in Southeast Arizona. So we're raising funds for that nonprofit. We raise funds in our nonprofit for patients to get access to this type of care because it's not available to everybody. And so that's one of my biggest passions. And then I think I'm speaking at about 30 more conferences this year. So spreading the word in medical environments, in patient environments, in business, corporate environments, whoever will listen, for crying out loud. Now that we know that 1 in 2 of us will likely meet this diagnosis in our lifetime, this is hopefully one of those ways that we can turn that statistic around.
Thanks so much for everything that you do. Until next time.